Good evening, everyone, and a very warm welcome to all the participants and our esteemed panelists today. Welcome to our webinar series conducted in a partnership with Thyrocare and HaystackAnalytics. I am Sanjana Kuruwa. I'm the program manager at HaystackAnalytics. The theme of our webinar today is precision management of TB, the relevance of whole genome sequencing. Talking about this topic will be Dr. Jay, consultant chest physician at PD Hinduja Hospital, and Dr. Chaitali, head of infectious disease at Thyrocare. Precision management is an innovative tool that takes into account very detailed information to provide the most appropriate therapy to the patient. The advantage with this is the chances of the patient responding to treatment is going to be higher because you're giving the right treatment. This is now gaining a lot of popularity today. So precision medicine in TB adds another aspect of importance. Today, treatment is available. TB we know is curable, but yet the mortality of TB runs into millions. TB is a complicated disease. Layer that with complications in detecting the cases, then treating the cases and keeping them on therapy. There are several issues. So treatment is a challenge, and more so also in cases of drug-resistant TB. To treat drug-resistant TB, you need to know what are the right therapies that you can give. This is where precision medicine becomes very important. Moving on to whole genome sequencing in precision medicine. Now, as the name suggests, it has the word whole in it. Whole genome sequencing looks at the entire genetic material to be able to identify which drugs the TB bacilli is sensitive or resistant to. In this way, we are able to give a complete picture of how many drugs are sensitive or resistant with a single test tool. About a decade ago, whole genome sequencing was used a lot in the wings in research, but today it has become a very, very good and valuable tool in the hands of public health. This gives extensive knowledge because you're looking at the entire TB genome. And with this test, you can choose the right therapy, even in cases where there is resistancy. You know which other drugs are sensitive and you can give treatment accordingly. So this therapy is now, test is now coming of age, and it has been recommended by several authorities such as the WHO and the PMDT. Talking further about this is going to be our esteemed panelists. So I would like to first delineate to you all the agenda of our webinar today. This webinar, welcome everyone again. And we will start off with a presentation from Dr. Jay, followed by a presentation by Dr. Chaitali. And this will be followed by a Q&A session. For the question and answers, we will explain to you all in the following slides the format of how you all can ask questions at the end of the two talks. I would like to introduce now Dr. Jay, our chief guest speaker. Dr. Jay is DND and FCCP with more than a decade of experience. As I mentioned earlier, consultant chest physician with the PD Hinduja Hospital, and he has a very, very keen interest in MDR TB and was a part of the first cohort with Vedaquilin in India. He is the organizing secretary for National Update in Respiratory Medicine, and he has several research papers in renowned national and international journals. Talking now about Dr. Chaitali Nikam. She is the head of infectious disease at Thyrocare Labs. She is a very active member in TB, member of the constitution of the National Technical Working Group on private provider engagement under NACP. She's a member of the National Technical Working Group on collaboration between NTP and corporate hospitals and labs. She has many, many publications in national and international journals as well. So welcome to Dr. Jay and Dr. Chaitali. I will now invite Dr. Jay to please give his talk. I'm sorry, just before we start, we'll just let you all know how you can ask questions. One way is that you raise your hand and we will call on you to ask your question. The next way is you can put your question into the Q&A chat box and we will come through to the questions one by one. In case we run out of time, we will give the answers to the questions via email. Dr. Jain?
One second. Am I able to share? Just 1 second. Can you all see? Hello?
Yeah, Dr. Javi, you have started your it's visible.
Well, able to see my slide?
Yes.
Yeah.
Yeah.
Yeah. Okay, so thank you, Ms. Sanjana and Thyrocare for having me here. This is an exciting new field, and even I get to learn a lot about this from sessions like this. So we'll be generally first speaking about whole genome sequencing in TB. Is it a boon or a bane? So we know that TB diagnosis has moved leaps and bounds over the last century. And initially, it had started from phenotypic tests like smear microscopy and solid and liquid cultures, which had a reasonable sensitivity for pulmonary TB, but not so great for extrapulmonary TB. And cultures often took quite long to come positive. Genotypic tests have now in the last decade or so come into play and have become the standard of care, especially in diagnosis of drug-resistant TB, which is really the problem statement for us going forward, because sensitive TB, as we know, can very well be treated in 6 months with 4 drugs, and you don't really need rocket science for that. So standardization of procedures is still difficult as far as phenotypic tests are concerned, and the correct performance of DST requires understanding of several steps, such as the origin of resistance and interpretive criteria, dosage and stability of the incorporated compounds, antimicrobacterial activity of the incorporated drug, and interpretations of results and data reporting. As we know, most of our DST results are based on critical concentration rather than MIC, which have been set up by the WHO. Coming back to genotypic tests, so the first one that came into play was the expert MTB RIF, and this is really a point of care test, and it revolutionized the way we looked at TB. Turnaround time of just 2 hours with a cartridge based test, and it detected not only TB but also rifampicin resistance. It detects regions of mutations, but it does not pinpoint any particular mutation, and sometimes may over detect by detecting silent mutations. It needs about 130 bacilli per ml, with culture we know is about 10 bacilli per ml. And the newer Gene Expert Ultra, which is now available, is probably even more sensitive than culture, and it goes up to 6 bacilli per ml, but sometimes, whether does it pick up dead bacilli or not, we don't know. But in a fresh case, of course, we can rely upon that. We also have the Expert XDR, which can detect isoniazid and rifampicin along with the fluoroquinolone and SLI, to give you what was the old definition of XDR TB. Then came into the line was the line probe assays, or the Haynes test, and this was the first line and second line, and this detects MTB as well as resistance to HR, fluoroquinolone, and second line injectables. That's amikacin, capreomycin, and kanamycin. And with most drugs, it can tell you the gene that has been involved, like example CATG or INHA with isoniazide. It can tell you the confidence of resistance, especially with fluoroquinolone, whether it is high confidence mutation, low confidence mutation, and where likely high dose fluoroquinolones may be useful. It is more reliable in a smear positive and pulmonary samples and pus, extrapulmonary samples, and especially with pleural fluid, CSF, etc. It doesn't do that well. And as we know, as said, it can provide high level as well as low level resistance. So these are just some of the mutations that we can get with high confidence resistance markers, and this can probably replace DST, as if you have a culture positive and you run this, you might not actually need a full-fledged DST, which takes another 3 to 4 weeks. So you have genes for rifampicin, INH, fluoroquinolones, and SLI, and you also have low confidence genetic markers where you might want to look at the clinical scenario and maybe confirm with a phenotypic DST when there are the list of these mutations in them. So other genotypic tests, one is pyrosequencing, which looks at specific mutations. It has a good yield with on culture and as also with certain samples such as CSF. You have next generation sequencing, and then of course we have whole genome sequencing. And as we know, going ahead from expert MTBRF, which basically anybody can run, to the whole genome sequencing, obviously these are a lot more complicated tests, requires a lot more expertise, higher safety level laboratories, etc. And so it's not easy for everyone to do it. At the moment, of course, whole genome sequencing would be a little bit cheaper than getting a phenotypic culture in DST, but the skill levels required are totally different. So whole genome sequencing diagnosis rapidly shows the exactly affecting MTB strain. So it can tell you, whether there's been a change of strain. As we know, there are certain multiple strains like B gene strain, etc., which are prevalent. Second includes the complete drug resistance profile. It allows the clinician to identify the best treatment at outset to combat the disease rather than starting off with empiric treatment. The implementing of whole genome sequencing can provide the National Tuberculosis Program, providing data for surveillance of resistance to anti-TB drugs. As you know, if there is increasing frequency of certain mutations, maybe you can, in certain areas of the country, maybe you can change the regimen in those areas to counter that. And then it's an important information for high burden countries to set TB control strategies and priorities. So what are the advantages? We know that it detects MTB. It can detect mixed infections. Sometimes you have a mix of sensitive and resistant TB. It can give you a quick genotype pick DST to about 18 drugs. It has a rapid turnaround time of about just 10 to 12 days compared to 4 to 6 weeks in culture. And it is cost effective compared to culture and DST. So this is just a schematic diagram as how the test is run. And you have a sample collection, then you have something called as culture enrichment, followed by DNA extraction. Then you have the pre-sequencing preparation. Then there's the actual sequencing that is done. And then there is data analysis, and a report is generated, which is automated along with the software. And of course, that the sequencing that you do and the mutations you do get are then compared with probably an internationally verified library of gene mutations as to which mutations correspond to resistance, which don't. And as a result of that, you can get a proper report. So this, you get something like this as a sample report as to which drugs are resistant, which drugs are not. And you get an antibiogram where you have these red, the drugs in red are the ones that are resistant, and the drugs in green are the ones that are susceptible. And then you can choose your drugs based on the drugs available. So it's definitely safer. It has reduced sampling, handling, and culture handling required. It is safer for the lab team because of the operating protocol. It is automation of lab flows and liquid handling. and bioinformatics. It has inbuilt quality check and data checks, and real-time digital data. It originates the digital data auto-feed into the Nikshay portal, so the physician doesn't have to re-register the patient. As we know, every new TB patient has to be registered with the government now. And data-driven public health monitoring, treatment and supply planning opportunity. So, caution, we need to look at clinically relevant mutations based on international databases. Silent mutations should be ignored to avoid false diagnosis of drug resistance, and that can change the prognosis and treatment of the patient. So it can provide greater resolution than conventional genotyping for investigating recent TB transmission and drug resistance, especially, is it a relapse, is it a reinfection? If you have the previous genome sequencing of the patient, you can make that decision as well. It's a one-stop source for curated genotypic and related metadata from MTB strains. And there is transitioning using whole genome sequencing as the standard method for TB diagnostics by providing antibiogram of 18 drugs within 10 to 12 days at an affordable cost. And as we know, countries like the UK, they have made whole genome sequencing as standard of care. Of course, the TB load there and the drug resistance load there is much less compared to India, but that would probably be the way to go, in the future. Thank you.
Thank you very much, Dr. Jay. Thank you for that informative talk, detailing out all the current tests that are available and juxtaposing that with the whole genome sequencing that's available also. I now call upon Dr. Chaitali to please give your talk.
Yeah, sure, Sanjana. Hope my screen is visible. Hello?
Yes, Dr. Chaitali, we can see.
Yeah. So, good evening, all the participants. And today I am talking about TB whole genome sequencing. What is the impact on detection of the drug resistant? What will be the benefited TAT and affordability of the same? So when any clinician is treating TB, what are the standardized regimens which is impacting the treatment? That is the MDR treatment success and the patient survival is depending and associated with the use of selected drugs, the use of a greater number of effective drugs, and the duration of treatment. So for treating TB, it's far more important which drugs to be used. And for that, the test which we do for knowing the drug resistant is far more important than this. So basically, we are signaling the clinician which drug to be used to treat the treatment, because we all know that treatment for DRTB lasts for long. So this is the algorithm. So if we see where we can position the whole genome sequencing or sequencing, so when it's already incorporated into this where genotypic tests are there. So after happening that after the gene expert, which is happening at the government site in public domain, whether it is a rifampicin resistant or susceptible, it goes for a line probe assays. Basically, in all areas where limited infrastructure is there, LPA takes lots of time, where we generally divide our TAT into pre-analytical TAT, laboratory TAT, and post-analytical TAT. So when these samples are get picked up from such a interiors, and then it goes to some intermediate lab for the testing, the turnaround time between the patient who gives the samples for gene expert and then depending on his rifampicin resistant, when this sample is getting tested for line probe assay, whether it's first line or second line, and then when they're receiving the treatment, the complete TAT, which differs from sample given that is a pre-analytical TAT to post-analytical TAT, is huge. Even though it says that it takes 4 to 5 days, but then the patient received the report in the hand is huge, because the infrastructure and the expertise which requires to do this testing is not available in all the laboratories. After line probe assays get resistant to any of the drug, the patient needs to go for a culture, and for TB culture, 42 days is a dream or average that which takes by the culture to grow, because as we all know that TB is a slow grower, and after that eventually it takes 2 weeks to get the DST, that is the drug susceptibility testing for it to determine the drug resistant, and it is for selective drugs only in the public domain. So this whole algorithm, if goes for a culture and DST, would take almost 58 to 60 days, which comes to 2 months totally to just initiate or knowing the drug registered in MDR cases. This is the guidelines, as we all know, which is published in March 2021, and which says that the genome sequencing has great potential for rapidly diagnosing drug-resistant TB in diverse clinical reference laboratory settings. Also, sequencing approach overcome many of the significant challenges associated with conventional phenotypic testing, as well as the limitations of other less comprehensive molecular tests by providing rapid detailed sequencing information for multiple gene region or whole genome sequencing of interest. So Dr. Jay has already described about low confidence level interventions mutations or high confidence level mutations, where drug resistant is totally depend on. So all this kind of result or all this kind of a challenges, when we says that genotypic or phenotypic DST is not matching, sometimes genotypic rifampicin resistant of gene expert is not matching in some time of a LPA cases, to rule out the relapse cases of the TB or follow-up cases, which is again giving growth on the patient sample in MIGIT. In this situation, whole genome sequencing is definitely causing a much impact for finding out the important drug which can be used to treat the TB. And that's what's already in the guidelines of PMDT, which has been published. So WHO recognized the potential of genomics-based DST and released the complete guideline and tool to implement it. So NHS was the earlier adopter of this technology and also found the genomic can effectively replace several DST methods currently used in India as well. So when we say about turnaround time or benchmark for turnaround time, which I have been described in when I'm described the algorithm. So if you can see in this chart, when it comes to NAT, that is a gene expert, which generally happens at the public domain. So it takes pre-lab TAT of 1 to 2 days, lab TAT of 1 to 2 days, and post-lab TAT of 2 to 3 days. So basically only for rifampicin, patient gets the report after a week. Same happens and which we have described for LPA, which says about 5 to 9 days, that is 1.5 weeks. Culture DST, as we are already discussed, that goes into 29 to 58 days, 29 in the cases where patient sample status is positive, where organism can grow rapidly, and if it is grow faster than 42 days, which is average TAT, then definitely DST also happen fast and patient can get the result for this. This is about the follow-up cases again, where there is a instability of the organism that may be present in the body, and it takes almost 1.5 months to know the liquid culture of particular follow-up of the patient. So definitely DST is considered to be a gold standard in TB diagnostic, that is a TB phenotypic, because it gives you the result of a live bacteria in the body. It's not about the genotypic, whether we are not knowing whether the gene which or the DNA which has been extracted from which type of organism it is. But even though there are few technical challenges in traditional TB, which has been already mentioned by Dr. Jai, where we needs to know that is the standardization of a procedure, it's still difficult to set up. The correct performance of a DST requires the understanding of several steps. Also, there are few new drugs which are being used in a TB diagnosis, and the trials and the critical concentration are still in the pipeline or the evaluation. So when we compare about phenotypic and genotypic DST, so genotypic approach have objective and measurable parameters that can be used for quality control, and molecular methods are less operator dependent than conventional DST. When it comes to conventional DST, the person who is performing the DST should understand all these four things, that is origin of resistant and interpretative criteria, doses and stability of the incorporated compounds, antimicrobacterial activity of the incorporated drug, and interpretation of the result and data reporting. This is the most crucial things, and these are the challenges in traditional DST where we require very, very technical staff to perform the test. So source of error such as sample mix-up or clerical errors may be occurs in both molecular and phenotypic methods, but the factors like the critical inoculum size require experienced technicians to reduce the variability of phenotypic DST methods. So few of the error rates has been catch up in this publication, which has been published in PLOS One by Nicholas et al. So it says that the error rates for TB-DST by phenotypic method and molecular methods are when grouped by individual drugs. So if we can see the red bar, which is indicating phenotypic DST, the green bar indicating DST on crude extract using molecular tools, and the blue bars detecting the DST on culture using molecular tools. So if you look closely, the error rates varied substantially between drugs. For PZA was consistently the most problematic drug, and of all the drugs, also susceptibility followed by amikacin and ethambutol and streptomycin are less as compared to PZA, and the proportion of incorrect results for second line drugs for fluoroquinolones and kanamycin was lower, and that is similar to INH and rifampicin. So these are the challenges or error rates which are already there and published in Well Impact Factor Journal. So as we say is that the type of mutation will be relevant for the patient's management, that has been low confidence level mutation or high confidence mutation level that we need to check. And also not all the mutations affecting DR associated genes are equal. We need to remind this when we are reading any RPO results. The identification of the nature of the mutation is a need for accurate diagnosis of a resistance, and the identification of a nature of a mutation is a need for the interpretation of the resistant label that has been already explained by Dr. Jai. So basically when we are saying about whole genome sequencing, so what we are basically looking for and what is the need of doing all whole genome sequencing is whole genome sequencing rapidly shows the exactly affecting MTB, including its complete drug resistant profile, and thus allows clinician to identify the best treatment regimen to combat the disease. Also, implementation of whole genome sequencing will benefit the NTP, providing data for surveillance of resistance to different anti-TB drugs and important information for high burden countries to set TB control strategies and priorities. So there is urgent need of understand SMP-DST relationship, understand SMPs and clinical outcome relationship, understand frequency of mutation, improve statistical power for rare mutations, understand the geographical distribution of mutation, standardize interpretation of SNPs, guide the development of new molecular diagnostics and new policies, and understand additional relationship, lineages, mutations, transmission, or compensatory. And what are the barriers right now in this are data sets scattered across high number of studies when we go through any of the publications. Different studies use different methods for comparison, that is a solid or liquid culture, SMP detection approach. Few studies correlate with SNPs to MICs, that is minimum inhibitory concentrations. Few studies correlating SNPs with clinical outcome, and few studies on functional genetics. We need to include all genes for all drugs, and we have to consider all these things when we are talking about doing whole genome sequencing. In a nutshell, the need for doing whole genome sequencing is clinical improvement or decision making for the clinicians to use it for a clinical research. It should save the time to start the treatment. It should scale up in the laboratories. It should save the cost as compared to the phenotypic DST along with the time. It should intelligently updated catalog should be updated and can be used. It should integrate new mutation detection seamlessly, compatibility with sequencing platform, comparison DST AMR, and it should identify mixed infection. So we thought of all this, what is the need of an hour? And with Haystack analysis, Thyrocare launched the TGS, that is a TB whole genome sequencing or TB genome sequencing in partnership with the HaystackAnalytics. At Thyrocare, we are having a lab of a class 2A1, which is ISO, NABL, CAP, and NTEP accredited for all required DST algorithm by genotypic and phenotypic methods. So with Haystack, we have automated, up-to-date, and tamper-proof protocol, which we are using in the laboratory, which requires 1 to 5 days of enrichment. That is, we are not replacing culture. Definitely this type will totally depending on the sample to sample, depending on the positivity of the sputum or positivity of the sample for smear status. If it is a 1+, 2+, 3+, definitely sample will culture fast or enrich fast as compared to the samples which is having smear status absent or which shows scanty bacteria on smear. It is secure protocol which we are using, tamper-proof and fully automated with time and machines stamping. It is a rapid and giving continuous updates, which is dedicated. The Haystack is having dedicated team for catalog updation, and they're using standardized bioinformatics for the same. This is the difference in between whole genome sequencing along with the other genotypic or phenotypic method, which are currently in the setting up in the algorithm or can be used. That line probasis gives targeted mutation for first line or second line group of antibiotics under line probasis, which is having TAT of 4 to 5 days. CBNAT is a gene expert. We know it gives resistance only for rifampicin, and turnaround time on the catalog for this is 24 hours. Now CBNAT has come up with 10 cartridges or 10 color systems which detects the resistance for more drugs, but here cost and deployment of the software or the instrument in the is a challenge. Then there is a culture DST, which gives you report about 12 to 14 antibiotics, which is with the critical concentration, which is given by WHO. But as we have discussed already, it takes 3 to 6 weeks to get the results. It is a problematic in case of a load of a bacilla. If there is a load of bacilla is low, then it's difficult to grow the culture. Also for extrapulmonary TB, it may be challenging. When it comes to TGS, that is a TB genome sequencing, we are reporting and giving antibiotic coverage of 18 antibiotic. And if smear status is positive, definitely the TAT would be less than 15 days. Also, along with antibiotic resistance, it is giving other information about strain identification, whether it's a mixed infection or co-infection. This is the report format which has been shown by Dr. Jai. But if you can see the percentage, what is the lineage, which is already which we have given, it's very easy to understand for particular drug whether if resistant is detected or not. Anyone can understand this And I would like to say this is a paradigm shift in genomic reporting, where clinicians are getting such a wonderful report where they can easily check, I can use which drug for this by looking at the diagram, where red color is the antibiotic where mutation conferring drug resistance is detected, whereas green color are the drugs where mutation conferring drug resistance are not detected. Along with this, at the end of the report, we are giving you whether it's a mixed infection identified or not, or any other pathogen identified or not. On the page behind, we are giving you typical picture of the mutations which are associated with drug resistant, and that can be easily understood by clinician again. In a nutshell, we can say that whole genome sequencing or TB genome sequencing can provide greater resolution than conventional genotyping for investigating recent TB transmission and drug resistance. This can be used by NTEP or the algorithm or the policymakers to understand the level of resistance where the infection is transmitting. It is a one-stop source of a curated genotypic and related metadata for MTB strains. And we are transforming using TGS as the standard method for DB diagnostics by providing antibiogram of 18 drugs within 12 days at affordable cost. That's from my end. Thank you for your patience listening, and we are open for any questions, if any. Thank you.
Thank you very much, Dr. Chaitali, for detailing out the TB WGS test. I will request the participants, if you have any queries, please post them into the Q&A box, or you can raise your hand and you can ask your question.
So there is one question so you can take that about that, Sanjana. It's a question and answer.
There is a query here, Dr. Chaitali, by Dr. Firuza. Female genital TB is a paucibacillary disease where culture rarely comes positive. In that case, how can we proceed with the test?
So, doctor, would you like to take this question, Dr. Jay?
Yeah, so I mean, it would depend, whether sometimes if it's very low, even if the bacterial very low, if with culture enrichment, if they can get enough genetic material to get the whole genome sequencing, that's possible. But sometimes it might be a negative thing, and then you might have to look at it empirically. But I agree, in paucibacillary conditions, we are not exactly sure how to do with it. But hopefully we might get better techniques in time to come, where even in such scenarios we'll be able to get enough genetic material. Maybe one thing is that probably you don't, when you send a sample, don't ask for decontamination. Make sure that it's done without decontamination or something like that. Probably it might help, but other than that, I'm not sure.
So basically so technically when it comes to paucibacillary type of a samples, so definitely there is a decontamination procedures which happens at the first phase when we receive the sample, like pus or any other sample which is already a paucibacillary, or their decontamination is a procedure. The pH of these reagents is adjusted so that only TB bacteria can be viable, and other bacteria which may cause contamination, may get killed in this procedure, and we can get the growth of a TB bacilli. And that's from technically from laboratory side.
Thank you, Dr. Chaitali. So we have a couple of queries requesting the tag. Dr. Chaitali, as you have mentioned, for the smear positive, smear negative, I request if you can just repeat that part for the attendees.
Yeah, sure. So
Thank
when
you.
we speak about a smear status positive or negative, so for whole genome sequencing, the first step which we are doing is culture enrichment. So culture enrichment is the part where we are decontaminating the samples, and we are, exposing the sample to, give the enriched growth of a TB bacilli. This, why we have to do this is we are sequencing the complete genome of TB, and for that we need a good quality DNA which can pass all the QC tests, which requires technically to be subtle to go for a whole genome sequencing. So for that, we are enriching the bacteria and we are made it viable so that we'll get good amount of a DNA. So if smear status is absent, in that case, it's become difficult to culture it in such a low period, that is of 5 days. And then we may require to culture it for a long or enrich for a long. And after getting good amount of a DNA only, we can go for a whole genome sequencing. Otherwise, QC may get failed, and then after 15 days, we may not get the results. So this is basically precautionary measures which we are taking to give a good quality report for the patients in particular in said data.
Thank you, Dr. Chaitali. Next question we have is, can we diagnose NTM by WGS? Dr.
Yes,
Chaitali, I will direct this to you.
Yeah. So as already in my presentation and also in Dr. Jay's presentation, we have already put up this point that definitely if it is a mixed infection with any other NTM or atypical, then definitely it can be ruled out by whole genome sequencing.
Thank you. The next query, Dr. Jay, I will request you to take this question. What is the strategy of treatment in a pneumonia-affected TB patient?
I'm assuming that patient has pneumonia and that's the cause has turned out to be TB, right? So now I would think that there's no real change in treatment as such. You would treat as you would treat any other TB. You look for, you look at the drug resistance profile and you give the appropriate drugs accordingly. I don't think there's any change in strategy as such, unless there are any complications like say hemoptysis or if there's hypoxia or something, that's a different issue. But otherwise, there's no real change in the drug regimen as such.
The next query is, can this test be done if midget is contaminated with pyogenic bacterial growth with mycobacterium, or do we require pure mycobacterial growth for this test?
So as we have discussed this already, so if there is a contamination, then definitely we need to subculture or revive the culture again, which is for TB. And TB culture reviver is the same technique or the procedure which we use to grow the TB. So basically, revival procedure takes same amount of a time when we start the growing the culture. So definitely it is possible to revive, but eventually it should not be contaminated more. So if it is a possibacillary or any other contamination which hampers the growth of TB bacteria, then it would be difficult to grow TB in such kind of samples.
Thank you. Next question we have from Dr. Kavi. What can be the sample from a non-healing ulcer suspected to have NTM infection? Dr. Jay, I'll direct this to you, please.
So you can probably take a good deep swab from the base of the ulcer and try and inoculate that quickly. I think that generally should be good. Or if you are debriding the ulcer, say any surgical procedures planned, then that whole tissue you can send off in saline to the lab. But if it's just a bedside test, then maybe just a deep swab should be good enough. But if debridement is planned, then the entire debrided specimen can be sent off.
Thank you. Next question from Dr. Vivek. Unlike CBNAT, can we send blood stain sample or a histopath sample for WGS?
So basically, CBNAT is, or any of the PCR based tests generally for TB diagnosis doesn't accept the sample which is contaminated with blood, because the main thing is that it may inhibit the PCR. And that's the reason bloodstained samples are generally unaccepted for any of the tests, whether it's CBNAT, whether it's LPA, or whether it's TB-PCR. Histopathology samples, that is the tissue samples, definitely we are accepting tissue samples. but that should not be formalin fixed or blocks. It should send in a sterile container or with the saline.
Thank you so much, Dr. Chaitali. This is one last request. If there are any final queries, if you can just post them into the Q&A box or raise your hand, we will take those questions. Dr. Lakshmi, please ask your question.
Hello.
Yes, Dr. Lakshmi, please ask your question.
Yeah. Extra pulmonary samples to be transported in normal saline for the CBNAT?
Yes, extrapulmonary sample, as in what do you mean by that? By tissues or any other material?
Tissues.
Yeah, you can transfer it in sterile container as well as in saline, no problem.
Okay, fine. Any culture for the urine in CBNAT? Urine, stool, it's not there, no?
So you want to go for urine CBNAT?
Yeah, CBNAT, 3 samples are deferred to do the blood,
Yes.
blood strain, urine and stool.
So stool is not
Any
not
advancement in
recommended.
technology? Any advancement in the technology?
No, not yet, because see, in CBNAT for Gene Expert, there are different sensitivities and specificities has been already given in lots of publication, where it is having less sensitivity and specificity for different extrapulmonary samples except sputum. When it comes to urine, the sensitivity and specificity is low. But even though if you have to check and you are suspected, then definitely you can send the sample. But definitely sensitivity and specificity is low as compared to other extrapulmonary samples and sputum.
Okay, fine. Thank you.
Thank you. We have one more question from Dr. Vinay. Can we send hemorrhagic pleural fluid for WGS?
Yes, definitely you can share pleural fluid for whole genome sequencing. But as we have discussed already, that EPTB, extrapulmonary TB, is already having less bacillary load in that case. So it will take time to enrich in the culture. But if it grows, then definitely we can take it ahead for whole genome sequencing.
We have one more query. What is the strategy of treatment in a COVID-19 affected TB patient?
Sorry, I didn't get the question. Strategy of?
Treatment in a COVID-19 affected TB patient.
So if it's a diagnosed TB patient, I mean, you give the standard TB drugs. I don't think that changes much just because there's COVID, and you treat the COVID separately depending on the severity. So I don't think that shouldn't clash. If you need to diagnose, then it's a different issue. Maybe you can send sputum, but if you need to do a bronchoscopy or something, then it becomes a little more challenging because it's an aerosol generating procedure.
Thank you. I believe we have come to the end of the questions that we have. So I will, thank you all for coming and attending this webinar, and also for making it a very wonderfully interactive session with all your queries. And I hope that you all had a very informative talk, and we hope to see you again soon. Thank you.
Thank you. Thank you, everybody.
Thanks everyone.
Thank you.